So, when a human body dies, what part of the human body dies last? Well, it's the pupils. Why? Because they dilate. And apparently, they're producing a movie, Hollywood is producing a movie about what happens to the human body when it gets constipated. Unfortunately, it didn't come out yet. Oh, sorry. Hello, everybody. It's Ryan here. Hope you and your folks are well. Today, we are addressing acute tubular injury. Here's an outline. We're going to be covering a clinical case and then dissecting acute tubular injury in terms of, first up, key points. Nice one. I included a new heading in the videos. Key points, which succinctly puts together what you need to know in a nutshell about the topic of interest. Then the introduction, and we're going to talk about aetiologies, how patients present in terms of signs and symptoms, a plausible differential diagnostic evaluation and investigative workup, treatment and management strategies, prognosis and complications, and then we're going to share scripture from the Bible. God bless you. Thank you so much for joining me. If you enjoy these videos, I encourage you to like, share, and subscribe. Righto. I'm a 57-year-old man today with a history of diabetes mellitus and chronic kidney disease. With a baseline creatinine of 204 micromole per liter, underwent cardiac cath for acute myocardial infarct. Right, now all these deals keep company, right? The myocardial ischemia, the chronic kidney disease, all sequelae of diabetes mellitus. Right, he is subsequently diagnosed with an acute kidney injury related to iodinated contrast, which they had to administer during the cardiac cath. Now, all of the following statements are true regarding his acute kidney injury, with one exception. What's the exception? Is it A, fractional excretion of sodium is going to be low. B, his creatinine is likely to peak within the next 3 to 5 days. C, his diabetes mellitus predisposed him to develop contrast nephropathy. D, transient tubular obstruction with precipitated iodinated contrast contributed to the development of his AKI? Or is it E, white blood cell casts are likely on microscopic examination of the urinary sediment? Key points, guys. So acute tubular injury, which is formerly called acute tubular necrosis, which I'm sure is a term that most of us are familiar with, refers to kidney injury characterized by acute tubular cell injury and dysfunction. Common causes, most common causes, claims to fame, are hypotension or sepsis that cause renal hypoperfusion, and of course the use of nephrotoxic drugs which cause the same. The condition is asymptomatic by and large until it causes the dreaded renal failure. Now, the diagnosis is suspected whenever azotemia develops after a hypotensive event, severe sepsis, or drug exposure, and is distinguished from pre-renal azotemia by laboratory testing and response to volume expansion. So you give the patient a trial of fluids and see whether the kidney function improves, whether urine output improves, right? Treatment is supportive. Okay, so like we said, acute tubular injury, previously ATN, refers to ischemic or nephrotoxic injury to the renal tubules. It is the most common cause of acute kidney injury in patients who are hospitalized, right? I did release a video on acute kidney injury, so I encourage you to have a look at that in your spare time to give you more of a background. Prompt and appropriate treatment of acute tubular injury may result in complete clinical recovery, which is true. Histologically speaking, the kidneys may nevertheless demonstrate fibrosis and permanent nephron loss, which then leads to an increased risk of chronic kidney disease in the future. Some patients may not recover fully and will have permanently impaired renal function. Okay, so this is our algorithmic approach as accustomadly the case. Okay, when we're addressing acute kidney injury, there's 20 causes to mention: pre-renal, intrinsic renal, and post-renal, the three brothers. And under intrinsic renal, there's 10 causes to mention: vascular, glomerular, tubular, and acute interstitial nephritis. So within the whole ambit or the world of tubular causes of intrinsic renal failure, that's when we encounter acute tubular necrosis. It could be on the basis of ischemia, which can be pre-renal failure as a continuum, right? Or it could be toxin related in terms of medication, contrast, pigment, protein. Medication, contrast, pigment, protein. Medication, contrast, pigment, and protein. All right, etiology, epidemiology, and risk factors, guys. Most often, we said acute tubular injury, ATN, Occurs due to ischemic injury or nephrotoxins. Ischemic acute tubular injury is often considered a continuum of pre-renal AKI when the underlying pathobiology is prolonged hypoperfusion of the kidney that leads to cell death. It may also occur due to hypovolemia from whatever cause, usually hemorrhage or dehydration, sepsis with or without shock, common in our setting, burns, hypotension, also common post-surgery, including obstetric surgery where there's a lot of hemorrhage, right? Your placenta previa, your abruptio placenta, etc., etc. Okay, nephrotoxic acute tubular injury, which is caused by direct tubular toxicity and or changes in the intrarenal hemodynamics, may be caused by whole truckload, guys, aminoglycosides, antivirals like tenofovir, acyclovir, amphotericin B, amphotericin B, nonsteroidals, cisplatin, cyclosporin, tacro, iodinated contrast agents, pigmenturia on the back of myoglobinuria in rhabdomolysis, hemoglobinuria in hemolysis, right? Organic solvents and poisons. Predisposing conditions include chronic kidney disease, especially diabetes mellitus and everybody's favorite multiple myeloma, sepsis, recent renal injury. And it's divided into a couple of phases. We're going to cover this. The initiation phase, which lasts hours to days, in which exposure to ischemia or toxin initiates your parenchymal injury. Then we have the maintenance phase, usually 1 to 2 weeks, but can last up to a year, in which parenchymal injury is established, and there is a sustained severe drop in your glomerular filtration rate, followed by the recovery phase, in which there's restoration of tubular function and an increase in the urine volume, which is what we call post-ATN diuresis, so-called, followed by a decrease in your serum creatinine, okay? As is customarily the case, we have Harrison's in here, talking about classification of the causes of tubular interstitial diseases of the kidney. So certified into acute tubular interstitial disorders, chronic tubular interstitial disorders, metabolic disturbances, cystic and hereditary disorders, miscellaneous. So we're talking about the acute form today, certified into acute interstitial nephritis, okay, caused by therapeutic agents. We've covered most of these, just to mention your aminoglycosides, your sulfonamides, your nonsteroidals, your diuretics, your anticonvulsants. Infections, certified bacterial, viral, and so on. Autoimmune, talk about Sjogren's, SLE, TIDU, which is tubular interstitial nephritis with uveitis, IgG4-related disease, acute obstructive disorders like light chain, cast nephropathy. We've mentioned myeloma kidney, and yeah, just to mention those guys. Righty. Renal tubular acidosis. What is this thing here now? It is a class of disorders in which excretion of hydrogen ions or reabsorption of filtered bicarbonate is impaired, which leads to chronic metabolic acidosis with a normal anion gap. We call it a NAGMA. It nags us a lot, ma. Normal anion gap metabolic acidosis. Now, renal tubular acidosis is usually due to abnormal aldosterone production or response, which is what we call hyporeninemic hypoaldosteronism, RTA type 4, or less often due to impaired hydrogen ion excretion, RTA type 1, which is distal renal tubular acidosis, or impaired bicarb reabsorption, which is proximal renal tubular acidosis, RTA type 2. You want to consider renal tubular acidosis if patients have a metabolic acidosis with a normal anion gap, NAGMA, or unexplained hyperkalemia. Check your arterial blood gas, serum electrolytes, urea creatinine, and your urine pH. Often testing is required to confirm the type of renal tubular acidosis, like acid load for type 1 or bicarb infusion for type 2 and so forth. Treat using alkali therapy and measures to correct low serum potassium for type 2 and sometimes type 1 RTA, and using potassium restriction or potassium wasting diuretics in hyporeninemic hypoaldosteronism type 4. Give other electrolytes as needed. So here we're talking about the anion gap, guys. To calculate the anion gap, sometimes, some people like to use potassium, other people don't like to use potassium, because potassium sometimes is excluded on the grounds that the value of potassium generally is small. But if you're incorporating it, anion gap is equal to your cations minus your anions, your cations minus your anions, your cations minus your anions. Sodium plus potassium, less chloride and bicarb, right? And your normal range is within about 16. If you 16 or less, that's what we call a normal anion gap metabolic acidosis. If your anion gap is more than 16, it's a HAGMA, high anion gap metabolic acidosis. NAGMA, HAGMA. So here is non-anion gap or normal anion gap metabolic acidosis, NAGMA. It nags us a lot, ma. And this is the handy mnemonic to remember the causes. And we, of course, are interested today in renal tubular acidosis. Alrighty, okay, here's a fun diagram from medcomic.com. Thank you to Mr. Jorge Muniz and company, outlining One of the causes of anagma, renal tubular acidosis. And we said here, let me just get my pen in there. Renal tubular acidosis affects the renal tubules and results in hyperchloremic metabolic acidosis with a normal anion gap, which is 16 or less. Right here we see a schemata of our beloved nephron. So we got the Bowman's capsule down here, we got the proximal tubule here, loop of Henle here, distal tubule here, collecting duct here. Very good. Now, guys, type 1 renal tubular acidosis is what we call distal RTA, and that hits you at your distal tubule, okay? And the claim to fame is impaired hydrogen ion secretion, right? Versus type 2, which is proximal, where the problem is impaired bicarb reabsorption, versus type 4, which is the hyperkalemic variant of RTA, which is known as hyporeninemic hypoaldosteronism. Hyporeninemic hypoaldosteronism. There's decreased aldo secretion or aldo resistance. So in type 1, your urine is usually alkaline initially, so urine pH above 5.5. You get hypokalemia. This predisposes to renal stones. Your alkaline pH predisposes you to renal stones. In type 2, the proximal variant, we said the problem is not with hydrogen secretion, the problem is with bicarb deabsorption. So you get the high urine pH initially, and later it becomes acidic at less than 5.5. Also hypokalemia, but no renal stones with type 2 proximal RTA. Type 3 is hyporeninemic hypoaldosteronism. Most common cause is diabetes, right? Urine pH is acidic, you end up with hyperkalemia. Very good, very much good. Okay, guys. That's another way to stratify the differences. Let's get my penny in there. Type 1 versus type 2 versus type 4, right? Type 1 is distal variant, type 2 proximal variant, type 4 hyporeninemic hypoaldosteronism. We're stratifying them in terms of primary defect, plasma bicarb, serum potassium, urine pH, urine anion gap, nephrocalcinosis. So in type 1, which is the distal variant, we said the problem is with impaired distal ammonium secretion. Type 2, the problem is with reduced proximal bicarb deabsorption. You can't recoup your bicarb, right? Type 4 is decreased aldosterone secretion or aldo resistance. Looking at your plasma bicarb, type 1, your plasma bicarb can be variable, usually less than 15, right? So it gives you a nagma, nags you a lot, normal anion gap metabolic acidosis. Type 2, your plasma bicarb usually sitting between 6 and 15. Type 4 is usually above 15. Serum potassium in type 1 and type 2 usually low. Right, and in type 1, you corrects with alkali therapy. In type 4, the potassium is high because it's hypoaldosteronism. Got it? Urine pH in type 1 is usually alkaline, but in type 2, initially alkaline and later becomes acidic, and type 4 is acidic. Urine anion gap is positive in types 1 and 4 and negative in type 2. Nephrocalcinosis only hits you in type 1, which is the distal variant, right? So guys, coming back to acute tubular injury now, let's get my camera up there. Okay. Most patients, or more common in patients who have significant comorbidities, change in urine output is important, right? There's different flavors. It can be anuric, where the patient pushes out less than 100 ml per day. It can be oliguric, less than 400 ml per day, or non-oliguric, which is sometimes termed polyuric, sometimes up to 3 liters or more per day. Symptoms of severe renal failure include nausea and vomiting, a metallic taste in the mouth, non-specific abdominal pain, lethargy, morning headaches. Patients may present with volume overload in the way of peripheral edema, pulmonary edema. Here, this beautiful bibasal crepitations, elevated jugular venous pressure. They may also present with other stigmata like encephalopathy, acidexia, excessive bleeding on account of uremic platelet dysfunction. Alrighty, it's a qualitative problem with those platelets, not a quantitative. Qualitative. Pericarditis, electrolyte disorders, and arrhythmias, usually on the basis of, hyperkalemia. Metabolic acidosis, which embarrasses myocardial function, predisposing you to hypotension. And you may have hypertension or heart failure. History often suggests the etiology, like hypotension from sepsis, medication usage, muscle pain from rhabdomyolysis. Differential diagnosis of acute tubular injury, guys. Other causes of intrinsic renal failure: glomerulonephritis, thrombotic thrombocytopenic purpura, TTP, vasculitis, interstitial nephritis, multiple myeloma, arterioemboli to the kidneys, pre-renal failure coming from acute hemorrhage from whatever cause, vomiting, excessive diuresis, diminished oral intake, diminished cardiac output, sepsis, cirrhosis, severe acute pancreatitis, post-renal flavor, benign prostatic hyperplasia, very common, urethral stricture, neurogenic bladder, urolithiasis, and pelvic mass. Don't forget cervical cancer, stage 3 upwards. Diagnostic evaluation, guys. How do we evaluate these patients? History first up. Take a good history, including recent surgery, which may have predisposed to a hypoperfusion of the kidneys on account of hypotension and hypovolemia. Hypotension, sepsis, volume depletion, exposure to nephrotoxins, especially amphotericin B, right? Diuretics, aminoglycosides, tenofovir, acyclovir, etc. Physical exam will be normal if early in the course, but findings of uremia may supervene later on. Urea and creatinine levels, of course, important to take. Urine microscopy, just as important. Urine often contains pigmented muddy brown granular cast. Pigmented muddy brown granular cast, which speaks to acute tubular necrosis or acute tubular injury, right? Diagnostic evaluation continued. Lab abnormalities depending on etiology includes hyper or hyperkalemia, hypo or hypercalcemia, hypo or hypermagnesemia, hyperphosphatemia. Anemia as well. Hypokalemia and acidosis may be present in amphotericin toxicity. Watch out. Hypokalemia and hypomagnesemia may be present in cisplatin toxicity. Elevated creatinine kinase and a urinalysis with hemoglobinuria, but no red cells indicate rhabdomyolysis. Assess your urine output. If it's between 100 to 400 ml per 24 hours, that's oliguric ATN, which occurs in about 30 to 40% of cases. In oliguric AKI, we need to calculate your FeNA, your fractional excretion of sodium, which is going to help you to distinguish pre-renal acute kidney injury, in which case if FeNA is less than 1%, from acute tubular injury more than 2%. If the patient's on diuretics, you can't use the FeNA. You need to use the fractional excretion of urea. So the fractional excretion of sodium is simply put, let's just have my pen in there. Righto, FeNA is equal to the urine sodium divided by the plasma sodium multiplied by the plasma creatinine divided by the urine creatinine times 100. So if your pre-renal AKI situation when your FeNA is below 1%, acute tubular injury, which is intrinsic renal, when the FeNA is more than 2%. Urine osmo is usually less than 350 milliosmoles per kg. In intrinsic AKI, urine sodium exceeds 40 because you can't recoup your sodium. You push it out in the urine, you dump it in the urine, and then you want to obtain a renal ultrasound to exclude post-renal obstruction. Renal biopsy is rarely needed if performed, typically shows proximal tubular injury. This is our beautiful myeloma cast nephropathy. Here, H&E stain of kidney biopsy showing atrophic tubules full eosinophilic cast. Oh dear. Cast nephropathy. Guys, treatment and management. Prevention is the best strategy. Hydration is a quintessential principle in management, right? With administration of some drugs, especially amphotericin B, where we have to prehydrate the patient with at least a liter normal saline before you give the ampho B. And once the patient's on ampho B, you want to measure your electrolytes at least every 3 days. Your potassium, your calcium, magnesium. You even give them, at least an amp of KCl in the fluid before you give the amphotericin B. The liposomal formulation of ampho B is significantly less nephrotoxic, right? But not always available. Hydration with bicarbosaline, N-acetylcysteine using low-dose non-ionic isosmolar contrast agents, possibly ascorbic acid, may decrease the incidence of contrast nephropathy in high-risk patients. Somewhat an area of controversy. Some people say that, N-acetylcysteine is helpful in the context of contrast-induced nephropathy, but the principle of management is good hydration before, so good fluid administration before contrast and after, right, which significantly reduces the incidence of contrast-induced nephropathy, especially in patients who have renal disease, diabetics. Avoid prolonged exposure to potentially nephrotoxic drugs, and we spoke about these deals right there. Monitor your blood levels of drugs such as calcineurin inhibitors, aminoglycosides. Avoid non-steroidals in those with underlying renal disease. Non-steroidals cause vasoconstriction of the afferent arteriole, which diminishes your GFR. Remember, what maintains your dilation of the afferent arteriole is prostaglandins, and non-steroidals inhibit prostaglandins. They cause vasoconstriction of the afferent arteriole. They drop your GFR. We know those stories. So also respond quickly if you notice that the patient has a diminished urine output or a rise in serum creatinine. Respond now. Don't wait. Otherwise, the kidneys are going to die. Pre-renal failure responds to appropriate intervention in the way of hydration if volume depleted, diuresis in congestive heart failure. Correction may prevent the development of acute tubular injury. Loop diuretics may effectively increase urine output but will not improve your GFR. Discontinuing offending nephrotoxins and redose medications for declining GFR. Monitor and correct your electrolyte abnormalities. Hemodialysis may be necessary for volume overload or electrolyte disarray. And remember that the 5 indications for chronic dialysis: refractory acidosis, refractory electrolyte disturbances, especially hyperkalemia, intoxication with dialyzable toxin like lithium and ethylene glycol, fluid volume overload, pulmonary edema, uremia, uremic pericarditis, uremic platelet dysfunction, uremic encephalopathy. A-E-I-O-U. A-E-I-O-U. Renal dose dopamine is not effective in the routine management of ATI, acute tubular injury, right? Treat concomitant medical conditions to ensure adequate nutritional support. Yeah. So here we have algorithm for the treatment of allergic and other immune-mediated acute nutritional nephritis. So you've got AKI with features of AIN, and you've got eosinophiliuria. Withdraw your offending agent, supportive care and close observation. If they improve, fantastic, nice, go on, carry on with life. If there's no improvement in 1 week or rapid progression and you're dealing with classic allergic acute nutritional nephritis, there is a role for glucocorticoids, corticosteroids. If there's atypical features, you want to do a renal biopsy and you can prove classic AIN, corticosteroids. If it's granulomatous or other immune institutional nephritis, you may want to consider immunosuppressive drugs, corticosteroids. If there's fibrosis, guys, you missed the boat, conservative management. Prognostication complications, guys. In hospital mortality may reach a whopping 50 through 90% in severe cases. It's an increased risk in males. Oliguric phase of ATI, multi-organ failure, poor nutritional status, patients on mechanical ventilation, and surgical patients. Death in ATI or ATN, usually on account of infection, heart failure, multi-organ failure, death due to uremia or arrhythmia, especially on account of hyperkalemia. But this is, of course, not as common because now we have dialysis. Thank God for that. Profound ischemia and significant comorbidities are associated with delayed recovery period up to 6 weeks or longer. Patients with contrast nephropathy often should recover within 3 to 7 days post-onset of renal failure. Even with recovery, these patients have increased 30-day mortality risk. Guys, coming back to our clinical case, we had a gentleman 57 years old, diabetes, CKD, acute MI. He underwent cardiac cath and angiography for his beloved acute myocardial infarction. All of the following statements are true regarding his AKI, except white blood cell casts are likely on microscopic examination of urine sediment. That is not true for this gentleman. This will speak to allergic interstitial nephritis, which is something different. Iodinated contrast agents, guys, are most commonly used in cardiovascular and CT procedures. They are a major cause of AKI. Serum creatinine will begin to rise some 1 to 2 days or 24 to 48 hours and will peak at 3 to 5 days, usually with resolution within a week. Urine sediment is bland without cast. It doesn't have white cell cast. Righty then. Okay, my friends, let's just talk a little bit about the Bible. There are many promises in the Word of God, promises that we can claim to be true by faith and believing in them, right? One of them is Proverbs chapter 10:22, that the blessings of the Lord make rich and add no sorrow to it. Hallelujah. What a wonderful promise. And blessing, I think, is more specific to our spiritual lives, right? What was regarded as prosperity and blessing on earthly terms was the old covenant thing, but what is in the new covenant is blessing in terms of spiritual things, to make us more Christ-like, to make us run after God and pursue Christ-likeness and holiness, like Paul said, to attain the stature and measure of Christ in our lives. And I pray that upon us, that the blessings of the Lord will indeed make you rich and add no sorrow to you as we persevere in serving Him faithfully and diligently. God bless you. Here are my references. Guys, you can catch me on Facebook. Just search for Internal Medicine Algorithms and Mnemonics. I encourage you to like, share, and subscribe if you enjoy this content. You can also catch me on Instagram and on TikTok as well. We're going to be talking about von Willebrand disease soon. Looking forward to that one. Take care and all the best.